Good morning and welcome to today's IAC webinar, Radial Access and Quality Update for 2020. My name is Kelly Bear and I'm the Creative Design Manager with Marketing Communications at IAC. Before we begin, I'd like to take a moment to review a few technical matters and let you know how you can participate in today's session. We would like today's webinar to be interactive, so we encourage you to submit questions. To do so, use the Questions tab located on the left side of your screen. Please submit your questions anytime during the webinar, as we will monitor questions throughout the presentation and try to answer as many of them as possible during the Q&A period. Also on the left sidebar is the Resources tab. Click on this tab for a link to today's handout, a PDF copy of these PowerPoint slides. Select the file name to download the handout. Lastly, in the lower left of the player, please note the Request Support button. If you experience any technical problems during this webinar, click this button. A technical expert will be there to assist you with any issues you may have. For those who like to take notes during the presentation, look to the right of the slides and click the Notes tab. There you will see a white text box where you can take notes on today's webinar. These notes will be emailed to you automatically at the end of the session. To be eligible for the ASRT CE credit, you must be registered, logged into this webinar, then complete the survey. The survey will appear on your screen automatically at the conclusion of the live session and also be available from the IAC webinar portal for 3 business days. If you are viewing this webinar in a group, please be sure you are also individually registered and logged into this webinar on another computer or device so that we have record of your attendance today. Today's presentation is being recorded and will be posted at a later time for on-demand viewing. This webinar is a joint presentation of IAC and Heart Rhythm Society. And now I would like to introduce today's guest presenter, Dr. Mladen Vidovich. Dr. Vidovich is Professor of Medicine at the University of Illinois at Chicago. He is Chief of Cardiology and Director of the Cardiac Catheterization Laboratory at Jesse Brown VA Medical Center in Chicago. Board certified in interventional cardiology, cardiovascular disease, internal medicine, and anesthesiology. His clinical interests include cardiovascular diseases, coronary interventions, and interventional cardiology. He is a member of the IAC Board of Directors and serves as president of the IAC Cardiovascular Catheterization Board of Directors as a representative of FSCAI. Dr. Vidovich has won several awards and honors, has been published in numerous books, websites, and abstracts, and has presented at national and international symposiums and conferences. And we are happy to have him with us today. And with that said, I will now turn this webinar over to today's speaker, Dr. Mladen Vidovich. Doctor?
Hello, thanks for the nice introduction. It's morning here in Chicago at 10 a.m., so thank you everybody for attending. So to add to this introduction, I will just say is the reason we picked this topic is because radial has really been pretty hot in the U.S. over the last 10 or 15 years. It's an interest in full disclosure is when I finished my interventional and general cardiology fellowship, I had done a total of 0 radial cases. Again, this was beginning in mid 2000s. Of course, we've made some tremendous progress, and now that 2020 is a nice round number, I think it's good to wrap this up and see where we've come from and how radial is really, in my opinion, a measure of a cath lab quality. I do have a research grant from Boston Scientific. Essentially, it's a grant to look at optical coherence tomography in the left main within the VA system. I think it should not impact this presentation. And then I did develop a radial catheter that Merit is making, so for which I receive royalties. I won't be talking about this. So it's usually good to start with a case to see what radial really does nowadays. And I think it's, I wanted to show all of you, I think you all come from various levels of involvement in the heart team to see how we've really made some progress. So this is done at our Jesse Brown VA Medical Center. So we were one of the first cath labs in the nation, actually the first cath lab in the nation to start PCI program, so percutaneous coronary intervention without surgical backup within the VA system. This was about 12 or 13 years ago. At that time, this was a big leap forward because, as you remember from history of PCI, is doing angioplasty without a surgeon on standby in the first days of angioplasty. That was before my time. Was really a non-starter. So this is one of your typical patients you would see in your practice. So chest pain, on exertion, progressive angina. Again, typical medical history: hypertension, borderline diabetes, former smoker, and on a reasonably decent medication regimen. You could argue that there's not enough anti-anginals here if you want to really push it that way. And again, physical examination, as it's frequently the case in coronary artery disease, you don't really see much. Again, maybe most of you, and I'll just take a break here about these cases. Everybody probably watched the ischemia trial that was just presented at the American Heart Association meeting in Philadelphia last weekend. And as you remember, they did rule out left main disease on all patients with a positive stress test. So here we are in the cath lab. So this is right radial access. You can see we are using a short catheter. It's like a smaller JL 3.5. It's a 6 French system. Again, standard radial. You can actually go 5 French very nicely. And you can see this pretty aggressively bad looking trifurcation. See this LAD going to the left. There is a very sizable ramus going in the middle. And you can see that this circumflex is a codominant lesion. So this is a severe ostial left main lesion. And then again, circumflex has disease, and as it's always the case with left main disease, you have pretty much disease in any ostial vessel. So this is another projection just to show you that we do have a left dominant system. You can see the dominant circumflex down there, and then a very large LAD. So what do you do with this really angiographically, and what do you do really with this with the radial approach? So again, you could conceivably say this, well, this can't be done radially because for this, we're literally going to need bigger equipment. We will need backup. We will need femoral access, and radial doesn't allow us neither support nor ability to deliver the liver equipment. Again, these are more additional injections, just showing you that this is really a distal left main lesion. As we all know, as left main has been tested in multiple trials recently. And again, this is also a large area of controversy. How you should do this. Should you do this surgically? Should you do this percutaneously? And the outcomes. I'm sure you're all aware of the debate about the recent left main trials, which have really taken this field to the next level, showing really big equipoise between surgery and percutaneous intervention. So again, just to show you that this is not a big RCA, but it actually had a CTO, and there was some collateralization from the left side that you saw on the previous system. So here is the interventional plan, and just take a deep breath and take a look at this. So this is going to be 7 French. So we are going for a left main intervention. We have trifurcation. We want to give options. We want to have options to do this with 2 or 3 wires if need be. We will use a standard femoral guide, which I think everybody is very well aware, which is going to be an XB 3.5 guide. And the idea was, since the ramus was spared from disease and the LAD and circumflex were widely spread, we can do a left main circumflex intervention. And then we chose the Coulot technique. So Coulot technique is one of the ways of doing this with left main intervention. Other options would be TN protrusion, which here I think would be tough to do because of the anatomy. Another option is DK crush, I think, which has very good results as well in the left main. But again, Coulot seemed pretty advantageous here because both the LAD and the left main were the same size. And then we chose heparin for anticoagulation. So this is a little cartoon. I think we can follow from the top, which shows you how you really do this. So you stent one vessel first, then you rewire in the step 3 the main vessel. Then you balloon the main vessel to open up the struts of the stent, and then you put another stent in the other vessel. You can start either way you want. You can do the LAD first and then circumflex, or circumflex LAD. This technique is really nice if both branches are the same size, because you don't have a lot of stent mismatch. It does cover the carina very well over here, but as with almost any bifurcation stenting technique, you end up with multiple layers of metal at some point. Here you would end up with multiple layers of metal in the left main. So let me show you how this really works. So essentially, as you can see here, we have 2 wires in both vessels, and you can generally pre-dilate as needed. I think it's not a bad idea to size and see the compliance of the vessel. So these were actually both pre-dilate. You can see the balloon in the circumflex here doing the pre-dilation. So here you can see the balloon, the same balloon arching here from the circumflex into the left main, pre-dilating the vessel. Right. So then this circumflex had additional disease, so we placed one stent in the proximal circumflex. This is the stent being deployed in the proximal circumflex, right? And then you can see this actually looks pretty good. See this is actually a very nice result in the circumflex. You can still see that there's left main disease over here. Okay. So then what will happen next is we will recross into the LAD. You can see the wire here recrossing through the stent into the LAD, right? And then now that LAD is wired through the stent struts, you can open up the struts, or fenestrate the struts as it's called. Now you can stent the LAD. So essentially you're placing a stent through the stent that was placed in the circumflex. And here actually you can see nicely in this different cranial projection, you can see the struts of the circumflex actually almost perpendicular, shooting through the barrel of that circumflex, right? So then you have to rewire this again, obviously, because you just placed the stent in the LAD. What is very nice to see here, and this is quite important for this topic, is the new equipment that we have nowadays, which was probably not available 10 and 15 years, makes everything better. Wires are better, stents are better, and they actually allow you to do way more complex procedure with smaller equipment. You see how this wire is now much more easily crossing. So then you do a series of post dilations to touch up the stents and make sure it's well opposed. You can see here a balloon again in the circumflex, another balloon in the LAD, and a balloon in the circumflex. So this is called FKB, or final kissing balloon. You can see this, both balloons are now up at the same time. Again, keep in mind, we're doing this 7 French radially. There you go. And this is what this looks at the end. Again, stents are nicely expanded. The ramus, which was the 3rd vessel, looks very patent and happy. So this is again, cranial projection shows excellent flow in both vessels with a left main intervention. So now you've seen what can be done with radial access. So what is really complex and what is really quality? That is the big question. So complex, really, if you ask anybody, doesn't really have such a great definition, right? You can define complex by any means, but I think most operators will agree that left main is not your garden variety simple case. So I think we can agree that left main is complex. Low ejection fraction. I think whenever you operate with low ejection fraction, you're talking about a more complex case, which may need left ventricular support, and the complications and the management of these patients ends up being more complicated. And then the issue becomes well, can you do left main radially? Can you do low EF cases radially? Is that safe? Calcification. what's happening in the last maybe 10 or 15 years is that as our preventive measures are getting better, calcified lesions are being more prevalently seen in the cath lab. And any curve that you see nationally is that calcification is growing, and that is shown by bigger emphasis on devices to treat calcifications. Rotablation, by orbital atherectomy, and then there's a new technology on the horizon, not approved yet in the United States, is the shockwave lithotripsy. So again, calcification with its complications by delivery and pretreatment of lesion clearly leaves the case at a more complicated level. Vein grafts and bypass grafts. Injecting vein grafts is not an easy thing. Takes manual skill. These patients are older. These patients are sicker. You will likely need more catheters. You will likely need more dye. So how you treat these patients, which may have also chronic renal insufficiency, generally places this as a more complex case. Bifurcation. I've shown you a left main bifurcation case. Most left main cases will be bifurcation cases. Some easy ones, and that's easy with quote marks, would be mid-LAD or maybe ostial LAD, but very frequently when you do left main disease, you are dealing with a bifurcation. The same is true for quite a bit of LAD diseases and obtuse marginal disease. Bifurcation techniques have advanced. We're now better with smaller guides, we're better with wires, but again, a bifurcation case is generally a complex case. Multivessel disease. You are, I'm sure, widely aware of the fact that when we used to treat STEMI in the past, we would just take care of the main vessel and then walk away. Now we're learning that perhaps we should be doing the non-culprit lesion as well at the same intervention. Same issue is with multivessel disease and chronic disease. Should we be doing more vessels at the same time? Should we be staging intervention? At any rate, when we see multivessel disease, it's more complex, it's more diffuse, lesions are longer, they're more calcified. Again, question is, how do you address this with which approach? And then there is the bread and butter of our intervention, STEMI. STEMI is maybe the least frequent intervention we'll do in some settings, but is the most highly visible and the intervention that has really the biggest mortality benefit we can get with our interventions. All these cases that I'm showing you right now, which are complex cases, can be done radially nowadays. And they can be done from the technical aspect, they can be done from the planning aspect, and some of them, such as STEMI, do show better outcomes when done with radial approach. So let's take a look a little bit about the rotational atherectomy. Calcium is the big kahuna of any interventional procedure. It does make stents more difficult to deliver. It does make stents harder to expand, and it's associated with worse outcomes if you don't do your job right. So the question was, and if you look at this graph on the right, you can see that in 2007, in the United Kingdom, about 20% of rotational atherectomy cases were done with the radial approach, and that increased to about 60%, versus the femoral approach kept going down. On the other side, on the left, what you also see is that there are more rotational atherectomy cases being done. So this shows two major really trends that's happening in the cath lab. One is you're doing more complex cases because calcified lesions just show up more often in the cath lab. Since you have to be dealing with calcified lesions, you have to do rotational atherectomy because you won't be able to do your procedure well. But radial approach, with its safety, because it allows you to do any intervention just as effectively as with femoral approach, but reduces bleeding because it's very hard to have a bleeding complications from the radial axis, has become a dominant strategy. So take a look at this, and this continues to grow. We don't have more recent data, but keep in mind, in the United Kingdom, which is about 80 or 90% radial, The radial intervention for rotational atherectomy has overtaken the femoral approach. Again, showing safety and ability to do cases. So this is this shows you complications with femoral and radial approach when you do femoral versus radial. So see, femoral is associated with higher complications rate than radial. And this is mainly because of less bleeding complications, right? So essentially your procedural success is the same, your bleeding complications are less. I know most of you are thinking right now as well, is this a prospective randomized trial? This is not a prospective randomized trial. This is an observational study, right? So again, with all the limitations of an observational study that people were not randomized, I think the decision to go radial or femoral was done by the operator. Nonetheless, in this sample, you see that the radial does win when it comes to safety over femoral approach. So then the question is, well, you could say, well, procedurally, I can do a better job femorally. I can get bigger equipment. I can do 8 French. I can deliver bigger burrs. I can do, you name it. This doesn't really hold true, right? So if you look at the procedural success, and this uses several studies. This is a meta-analysis. You can see that here the diamond-shaped dot on the bottom shows that there's really no difference in procedural success between radial and femoral. So again, UK study shows less complications. Meta-analysis shows same procedural success. And then, as I was mentioning as well, do you get more safety with radial access? And that is actually true. So you can see that since radial access is associated with less bleeding, in rotational atherectomy, you will have fewer bleeding complications with the same procedural success. Just take a quick look here at this number, 0.45. So that's about 30% to 67% fewer complications. The mean is 45. So you will probably have half the amount of complications bleeding-wise with radial compared to femoral. And then you could say, well, it's going to take me longer to do this radially, right? It's going to be more fluoroscopy. It's tougher to get in radial. My guides are not going to fit. This is really not true either. So procedural time is same with radial and femoral. So what I've shown you here is that radial access with a complex case, such as a rotational atherectomy, is associated with less bleeding, same procedural time, and same procedural success. Okay, I think this is pretty, I think, convincing data looking at a complex procedure. All right, so then, and I'll come back to this a little bit later, this is Dr. Schlafmitz, one of the higher volume operators in this country, in the US, who's actually published quite a bit of data about wide spectrum of interventional cardiology. You can say this is a high volume skilled lab. What they were able to show is that you can do same day discharge after PCI with orbital atherectomy, right? So this is again showing how the field has really advanced. So again, none of this really proves that you can do this with radial or femoral or any other axis you possibly want to discuss. But again, the field has advanced that radial access allows you to do the rotational atherectomy and you can send patients home. Again, complex cases can go home in a high quality lab. So then let's go a little bit to the future. So this, if you live outside of the United States, this is approved in the coronaries. In the United States, this technology is not approved in the coronary tree, but it's approved in the periphery. So this is a balloon, very similar to if somebody has kidney stones. So essentially you apply shock waves, and the shock waves can crack the calcium in the vessel, right? And you do this by introducing a balloon in the coronary, crack the calcium, and then proceed with the procedure. So this is like rotational atherectomy or orbital atherectomy another way of treating calcified lesions. In the United States, a trial is ongoing. You can see in this little cartoon is you inflate the balloon to a low pressure, so you have contact between the vessel wall and the calcium. Little shocks are being emitted. They crack the calcium, and then you can remove the balloon and then proceed with your interventional procedure. It is again, it is being tested in prospective trials for FDA approval. And in Europe, it's being used with actually reasonable success, both femorally and radially. So this is a intravascular lithotripsy case. You can see there is a big boulder here in the right coronary artery. This is after lithotripsy treatment, which actually cracked this boulder. And you can see here a pretty good result with excellent stent expansion. So keep your eyes open. This will come to a cath lab, your cath lab or cath lab next to you very soon. So let's talk about chronic total occlusions. So radial atherectomy is complex. Left main is complex. CTOs are complex. So if you talk to highly skilled, highly published, well-respected CTO operators, they will tell you that very frequently you need femoral access, because femoral access allows you to go with bigger devices, 8 French, 9 French, you name it. It allows you to do bilateral intervention, because if you want to do contralateral injection, or a variety of other options that may not be truly available radially. So take a look at the most recent data, which we have now from a data set in the published in this year. So bilateral femoral is 40%. You can see here on the left, but you can see that people are actually doing unilateral radial and femoral, bilateral femoral and unilateral radial, bilateral radial and femoral, bilateral radial. You see variety of options, including radial. So what is really happening in the field is that radial is growing, allowing us to do combination with femoral. So you can do 2 radials at the same time. You can do 1 femoral, 1 radial, in addition to the traditional femoral approach. Why this is happening is primarily because the equipment is better. So we are able to do complex CTO cases radially, and the recognition that the bleeding with radial approach is less than with the femoral approach, and then allowing you to have actually safe cases. So if you look at the next slide, you will see here is what's happening is with technical success, right? And you can see that no matter how you look at this, and this is the progress database, it's very similar, right? These are all numbers for whichever combination you want. Radial only, light blue, radial femoral, darker blue, or femoral only, yellow. You don't even have to look at the details. It looks that everything is about the same. So this is a great testament to show that no matter how complex the femoral the CTO is, whichever axis you use, radial allows you to do a combination or on its own CTO procedure. All right. So then, if you want to look at this, and this is actually pretty cool, is like, so if you look on the left, you can see complications, all right, and then you can see how the proportion of CTO PCI is increasing. See the blue line, and you can see how the complications are going down. And you can see on the right how the bleeding complications are going down and how the transradial CTO PCI is coming down. So it is likely, again, this is an observational study, but it is likely that by increasing radial access, by decreasing bleeding complications, you increase safety, and you're able to do CTO PCI at the same rate. Okay, so again, another quality metric of your cath lab is your percentage of use of radial in the PCI. So here, what you can see in the UK database is how the CTO PCIs are increasing. And again, this is very similar that you've seen anywhere in the world. And then on the right, you can see that percent of CTO cases done with femoral access is decreasing. You can see here, 84% femoral in 2006, and in 13 we're down to 57% radial. Again, you can see here that there is a little bit of a plateau. So if you wanted to draw the line all the way down here, you can probably see here a little bit of a plateau. And we'll talk a little bit about this plateau in a second. So this is something that you probably would have guessed. What I was trying to say so far is, again, access complications. Radial on the left, radial, femoral, femoral. You see access complications. So if you do only radial, they're less. Femoral are the highest. Again, so more radial, less bleeding. Same thing with the major bleed, 30-day mortality, and the transfusions. Again, you can see a pattern. You're taking a complex case, such as CTO PCI, you add radial access, and you end up with fewer complications. Right? So again, a quality metric with equal technical success, as I showed before. So left main. I'm sure I have to go back to the ischemia trial because Twitter was abuzz with that, and I think it was a very important trial presented at AHA last weekend. Left main, just to remind you, had to be excluded in all patients with positive stress tests. So it still is a lesion that requires some treatment. Even in the ischemia trial, which showed equipoise between medical management and intervention, left main was excluded from this trial. So can you do left main radially? Right? This is a big question. And again, those of us who have been around for a while, doing left main PCI did not sound such a great idea, right? It took about 10, 15 years, especially with interventionalists from Japan and Asia, particularly Korea, which showed safety of left main. So then, now we have to fast forward. Now it's 2018 in this study, and we're going into 2020. Is MACE, so major adverse cardiac outcome, just as safe radially as femorally, right? And if you look at this meta-analysis, indeed it is. So showing you that radial access is just as good for left main as femoral access. Okay, very, very important meta-analysis because there's a lot of thought out there, and you can see chatter on Twitter or that would suggest that radial is not able to perform as high complex interventions as femoral. But again, in this meta-analysis, this is not the case. And then, as I mentioned, any way you slice it or dice it, when you have radial access, you will have less bleeding. So again, sicker patients with left main, again, they'll have less bleeding. And then again, I showed you that with rotational atherectomy, remember this number was 0.45, here it's 0.39. This is generally the number you will get. So if you have 10 bleeding complications in the with your femoral cases, you will have 4 with your radial cases. Again, very important reduction in bleeding with same technical success. All right, so then this is a case we all do, and they're not easy to do. And just to say an anecdote, I usually cath on Friday at the VA because I'm 50% VA, 50% University of Illinois, and I noticed there's a lot of cabbage cases with vein grafts scheduled on my day. So ask my nurses, is this an accident? They're like, no, this is just random scheduling, how we do it. So then I did a little analysis, crunched our number, and it turns out they were putting them on my day. Whether that's good or bad, I don't know. But again, I could prove it that these cases are not to everybody's liking because you have to do more work. There's more dye, more radiation, more catheter manipulation, and a little bit of complexity again. So here is what's happening in the UK. And why am I showing you UK data, you will ask me, and why I'm not showing you US data? For one very good reason. We have the NCDR database in the United States. and UK has this database called BISIS, and they have really produced some highest quality research because it's a mandatory database. So everybody has to enter the data, and their UK is about 80–90% radial. So if you're looking for a country that produces high quality data with high volume radial, you have to look to UK. In the United States, we are only at about 40–50% radial, and our database is not absolutely mandatory for everybody, right? So you don't have to report everything to NCDR. So let me show you here what's happening with PCI in the UK with radial versus femoral access. You can see again, they start with 90% femoral, right? And then in about 10 years, they end up with 50 or 60%, right? So then again, graft PCI was more frequently done femoral. They only do it 60%. They do 60% femoral, and then 50% they do native vessel PCI radial. Again, very dramatic drop. So you can see that even in something pretty complicated, and everybody who's been in a lab for vein graft intervention knows that it takes some skill. Catheters don't fit well. You got to get better engagement. It's not that easy to do. Again, major push towards intervention radial. And then if you look at outcomes, again, very similar what you've seen with the rotablation. Again, slightly better outcomes. I think they were not statistically significant than femoral. But again, you're getting same quality, as you can see here, with less bleeding, right? And again, as the skill of British operators has increased, so has the rate of radial approach increased. So the question is, so what is really going on here? I'm showing you that radial is increasing. In the UK, it's probably 80–90%. Why are people really choosing radial over femoral? And this has been brought to me probably about 10 years ago as we were in the early days of radial in the US, and I was talking to a physician from Ireland. I think he was from Dublin, and I said, "Well, we do femoral here in the US, and we keep people overnight." And then he says, and then he almost started laughing, and he says, "Well, it's a little bit different here. We don't have beds, right? So for us, first we have to do radial because we can do a faster, bleeding-free approach, and we can send them home faster." And for them, radial was a no-brainer, right? It was cheaper, it was faster, it was safer, and they just did it almost. You almost see like out of necessity, right? And then I've shown you data. Again, this was 10 years ago. They've made some great progress. So this is a editorial I wrote a couple years ago. Based on that UK data. So this is what's happening right now, right? From 2005 to 2014, see, they went from about 90% to about 60%. And I was trying to predict the future here to see where will this go, right? So the red line would be, we'll go backwards, we'll go back to femoral access. I think that is pretty unlikely. I think we're training fellows now that are facile with radial access. I think cath lab staff is now familiar with radial access. Our nurses were just like us. We only knew how to do femoral, and we've all transitioned to radial. They're happier. Their work hours are happier. They don't have to put patients on bed pain. It's easier to ambulate them. It's easier to feed them. It's easier to send them to the floor. And nowadays what happens is, when we call to the floor and say, "Hey, we did a femoral case," you see there's some comfortable silence on the other side of the floor on the phone, because the nurse says, "Wait, this is way more work for me to deal with a femoral patient in radial." So I don't think one will happen. Okay, two, and I've shown you there has been a plateau in UK for complex intervention. Right, this could happen. Right, it is quite plausible that for complex intervention we will hit this plateau about 50–50. Right, and we won't go anymore with radial. why would that be the case? One is femoral is not a stable, unmovable field. Femoral is getting better, right? So we now learn that ultrasound-guided access is the way to go. And I think doing ultrasound for femoral access is your quality measure. If you're not doing femoral with ultrasound access, you probably shouldn't be doing it. So I think that is one of the reasons that radial may not be overtake completely femoral in complex cases. Closure devices will likely get better. There's no question that innovation will bring better closure devices. So I think if femoral stays competitive, and for which it'll need better access techniques, so essentially ultrasound or other measures of getting better access. And then I think if our closure gets better and it takes another leap, it is quite plausible that we'll be on the green line. 3 is continued growth of radial. And again, it is quite possible this will continue to happen. Femoral may not catch up. Radial may just keep getting better. Again, as there is technological advance in femoral access so that you can do big devices with less bleeding, it is quite possible that the technology advance with radial will also go that direction. You'll be able to do more with smaller devices. And that's why I showed you shockwave. Maybe it's completely possible that with smaller miniaturized devices, you'll be able to tackle more complex lesions with smaller equipment, for which you may only need radial. So again, what I wrote in this editorial, I'll be happy to revisit this issue in 2022 and 2023 and see where we stand. So again, jury's out. We'll see. I say both 2 and 3 are quite possible because technology is really advancing. So again, this is from a friend of mine. I got this, and it's now all over the internet. So you can Google it, from Jack Chen from Atlanta, a friend and colleague. I learned a lot about radial from him. Is radial has really, and as I told you about this Irish physician, has really helped us with same-day discharge. You can do same-day discharge, and again, this would be a complete different topic to talk about right now. Is you can do femoral same-day discharge femoral, and there's actually quite a bit of data with same-day discharge femoral. You can do the same-day discharge radial. It should be the standard of care in 2020, and as we are part of the ACC committee, and we're just finalizing our document. I'm the co-chair of the ACC document with Dr. Rao from Duke. And just to give you a flavor, we really analyzed all the data we have out there, how patients feel, how physicians feel, and what's really good for the healthcare system. And I think same day is the way to go. And the data that I showed you is, while you can very nicely do same day with femoral, it is a breeze with the radial. And I think it's very simple. You don't need bigger science, and I think we've published on that. But just ask a nurse in the discharge area which one do they prefer to send home, radial, femoral, and I think you'll get 10 out of 10 will tell you radial. So I believe, and again, the data is going that direction. Standard of care for 2020 is radial, and same day discharge is somehow part of this. And again, it's a buzzword transition from volume to value. I think radial is value and same day is value. So again, this is all part of the same process, cheaper, faster, and then more comfort for the patients. So how did radial conquer the world? I have 3 check marks here. Less bleeding. I think this is undisputable. Will femoral catch up? I think so. It will happen. Again, it's a steep curve for femoral to catch up because radial is really quite superior for bleeding. Sheets got better. All right. Radial was possible because sheets got better. It had actually nothing to do with femoral or operators or you name it. I think this is a testament for the companies. When we started doing radial, probably about 10, 12 years ago, the sheets were thicker and the hydrophilic coating was not as great. Now radial sheets are absolute pleasure to work with. They're thin, they're slippery, they don't kink. Vasospasm has become less. So again, this helped quite a bit. And this is not doctors, this is not nurses, this is not hospitals, essentially companies that actually just made better sheets, right? Radial and same-day discharge, as I said, they are match made in heaven, because it's way easier to drive home and knowing that you same-day discharge a patient with radial access than femoral access. Again, for femoralists listening out there, can you do radial with femoral? Yes, absolutely. Is there data for that? No question. But again, is this easier? Does this make everybody's life better? Absolutely. So then, this is quite important. Again, this is nothing to do with radial, nothing to do with femoral. We all remember days when stents were undeliverable. They were huge, they were short, they were thick metal, and it took a lot of work to deliver a stent. And when I work with fellows nowadays, and you place a 2.5 by 38 millimeter stent in a distal PDA, and it just flies in there through all the tortuosity, I tell the fellows that, you just don't know how good you have it. But again, stents did help radial, because you can just do better things with the same devices. Again, nothing to do with radial, nothing to do with femoral. It just helped the whole operation. I showed you a culotte case where we actually had to recross and do all sorts of contortions to get these stents. Wires got better. We can actually do way better cases now with the coronary wires. Again, radial has nothing to do with this, but it actually helps us do cases. This is I put a question mark here, and just in full disclosure, this lecture was prepared on Friday, finalized, and if you were following the AHA meeting last weekend, you might have noticed there has been a very, let's say, bombastic or explosive or profound, or you want to work a presentation about safety with left ventricular support, with the mechanical left ventricular support. So the jury's still out. I put that question mark out there, and I think that was good. Whether we should be doing LV support with PCI and how should we be doing it, it is a very complex question to be answered. But what I can say is radial does help you with LV support. If you have a balloon pump or an impella femorally and you have a radial access somewhere else, well, you just have one fewer groin to worry about. So again, radial does help you with this as well. And then lastly, I think we just got smarter. I think we just figured out that putting all this together, you can deliver better cases, you can get less bleeding, patients are happier, staff's happier, and I think everybody wins in the end. So my conclusion is that the way I see it, again, I'm a radiocentric radialist, but radial essentially means quality. I think the percentage of the radial you do shows how much you care about quality. Again, at many aspects, for procedure success, for bleeding, for discharge, and for overall happiness of the cath lab staff. So again, with that, I will conclude to leave some time for the questions. Again, thank you for your attention.
Okay, at this time, we will begin the Q&A session. From IAC, I'd like to introduce Frank Vermeeren, Director of Accreditation for Cardiac EP and Cardiovascular Catheterization. He'll be assisting us with the Q&A session today. Frank, would you like to start us off?
Yes, thank you, Kelly, and thank you, Dr. Vidovich, for this wonderful presentation. We had a couple questions, or actually had several questions. One started with the initial case that you presented with the culotte approach, and it's stated basically that the person worked in a state where they are not allowed to do high-risk cases without on-site OHS backup. And so since they're not allowed to do that, was that first case considered a high-risk case?
Yeah, so I would consider any left main a high-risk case because if you're not allowed to do cases like this without surgical backup, I would not consider left main any stretch of imagination a low-risk case, because the chance of getting in trouble with left main is substantially higher. So yes, I would say it's a high-risk case.
Thank you. There's another question that's one to know, is there a higher risk of stroke with intravascular lithotripsy?
That I actually don't know. That's actually a great question. I do not know. I don't know if there should be, and I will guess. What I do know is that there is less distal embolization. Right. So when you roto or CSI, you cause microparticles which distally embolize. Intravascular lithotripsy does not embolize, but I do not know the answer. But I'll take the opportunity to answer the question, is there a difference in stroke between radial and femoral? And that actually gets asked a lot. And the answer is no. The radial and femoral axis have the same incidence of stroke, because the question was, radial, I'm going across the carotid, going across the vertebral. So there's no difference in stroke with radial and femoral. For lithotripsy, I don't know. That's a great question.
Great. Well, thank you. Also, we had a question that says, has there been a study done to show post-discharge complications from radial artery access?
Yes, quite a bit. And that is a huge field of quality. So femoral, I'll make it very simple. Femoral, you bleed, right? And then you have to deal with bleeding. Radial has this, there are complications of radial. Biggest one is called radial artery occlusion, right? So in about low single digits, but probably about up to 5%, radial artery will permanently occlude. Right? It'll be asymptomatic. All right, so hands don't fall off, fingers don't fall off, but radial artery will get occluded. You can deal with this with a variety of quality measures, smaller sheets, giving heparin, giving vasospastic drugs, patent hemostasis when you remove it. This is a complete 1 hour talk how to reduce radial artery occlusion, but it is there, and it's not the zero. So if you're looking for radial artery complication, this one is number one. There are many others, but this is probably the top. It's asymptomatic, and it may preclude you from resticking the radial artery again. So yes.
Great. Well, thank you. What is the current evidence for ulnar artery access compared with femoral artery?
That's a fantastic question. So there's about 6 trials that compared radial to ulnar. There's no direct trial ulnar to femoral, but there's 6 trials that looked at ulnar versus radial. So first, size-wise, they're about the same. We used to think it might be bigger, but they're about the same. Ulnar is actually a straight shot from the brachial, right? So ulnar has fewer loops and twists and turns, right? Spasm is the same. Bleeding is the same, right? So they're probably the same, and it's a straighter shot. So you would think, why don't we do ulnar? Because it has fewer loops. The issue is radial has this big, flat, beautiful radial bone underneath the radial artery. So when you compress, you're compressing on a flat plane of the radial bone. Ulnar, if you look at the cross section of the wrist, it's deeper. There is a nerve next to it, and there's no big bone to compress it. So when you compress ulnar, you're really at a disadvantage, right? The way you do it is you take the radial compression band and just flip it 180 degrees, and you can compress the ulnar. So what happens is with ulnar axis, it's associated with probably more hematomas locally, right? And we see that in our practice. And I'll just take not to belabor this with ulnar, but it's actually very safe. And there's an operator in Macedonia, Dr. Kedev, who's actually probably the leading ulnar guru in the world. He accessed, and believe it or not, like this: so you had occluded radial, right? And then he accessed the ulnar on the same side, does the procedure, and then closes it. and found no complications with that. So it is extremely, extremely robustly safe, even in presence of radial occlusion. Again, but for day-to-day use, if you want to do radial or ulnar, radial is way easier because of the closure.
Great. There's a similar question here. Would you support distal radial access, and if so, why?
I love that question. And so distal radial access was invented by this guy. His name is Babunashvili in Russia. And what he was trying to do is he was trying to poke through the radial artery occlusion, right? So he didn't want to go from above. So he said, well, why don't I stick through the thumb and then try to poke from distally, right? So he was trying to do something completely different. So then people said, look, wait a sec. If you can poke through an occluded radial from the thumb, from distal radial axis, why don't I use this for my daily intervention? And then come Twitter. I'm sure you've noticed is that Twitter can be a huge political tool, but it's also a great distal radial tool. So it exploded on Twitter. And if you look, it's a hashtag LDTRA, right? Left distal transradial axis, because it was really popularized by doing left radial, because anyone that's done left radial know that it's actually bad for your back because you have to lean over the patient. But if you actually put the patient's hand pronated on the belly or belly button, you have this beautiful actually artery on top of the wrist. And it's good for the patient, it's good for the doctor, and if it occludes, you occluded a small artery on the thumb, you didn't occlude a big radial artery. So it's spread like brush fire on Twitter. I just reviewed, and then I wrote an editorial for a paper to be published in Cardiovascular Revascularization Medicine, CRM, from a great Greek group. So they did a comparative trial, radial versus distal radial, and they actually found that they could do whatever they wanted in the coronaries. So the issue was not in the coronaries, but their access failure rate was more. So again, and I'll tell you this, is it's very attractive. It's more comfortable for the patients, but I think it has several downsides. You probably need ultrasound to access it, so you can't just do it with palpation. Bleeding is probably about the same, and I think we still need a large prospective trial to see whether it's worth doing it. So it's clearly up and coming. I'm 50-50 data-wise whether to adopt it or not. I think it has its role, but I'm not 100% sure that it's gives you an advantage over regular radial access.
Great. These are great questions.
These are fantastic. Thank you.
Then we have actually a couple more, but we only have 1 minute left, so I'm going to go in order here. So we wanted to know if you had any issues with seeing pseudoaneurysm, and if so, what was the treatment for a radial pseudoaneurysm? So
just to get all the questions, so the answer is yes, very rarely. In most of the time, you just bring them back, put the TR band or the compression band on it, and they thrombose on their own. We hardly ever, I don't remember ever had to bring a surgeon in and do a thrombin injection or surgical resection. But if you look at the literature, yes, they're out there. It's very, very, very rare in my practice.
Okay, great. I think we still have some more time here. Do the chances of radial artery occlusion increase with same-day discharge versus next-day discharge?
And the answer is no, not at all. The way you really reduce radial artery occlusion is by giving intraprocedural anticoagulation and by doing patent hemostasis. And patent hemostasis is exactly with the window of discharge, and when you have to discharge them by any standard for your moderate sedation. So yes, so discharge has nothing to do with radial artery occlusion.
Well, great. So, well, thank you very much, everyone, for your wonderful questions. And I'm going to turn this over to Kelly.
Okay, great. Thanks again, everyone. And a very special thank you to Dr. Vidovich for this presentation today. Please feel free to contact IAC with any questions that were not answered during the Q&A session. To receive continuing education credit for attending this webinar, please complete the survey. The survey will appear on your screen automatically at the conclusion of this live session and also be available from the IAC webinar portal for 3 business days. On the left side of the My Account page, you'll click on Webinars, look for the title of this session, Radial Access and Quality, Update for 2020. Beneath this title, you will click Review Event. On the left, select the Evaluation tab, then click Take Evaluation to complete the survey. Your certificate can then be accessed and printed from the very next screen and anytime thereafter through the CE transcript section on the My Account page. If you have any questions about the survey, please contact us at webinars@intersocietal.org. Once again, we thank you for joining us today and appreciate your participation.